Alright, continuing right along, congenital heart defect. About word. Congenital. You're born. Anytime you hear that, congenital always means you're born. Congenital heart defect is a structural abnormality in the heart that's present at birth. Congenital heart defects are the most common birth defect. In 2013, and I do know this is 7 years old, 2013 congenital heart defects affect about 34.3 million people in the world. Currently, there's around 1.3 million Americans alive with congenital heart defect. Its incidence depends on diagnosis, because some of these do go undiagnosed. Around 100, 1 in 100, 1 in 110 every year are born with a congenital heart defect. And over here you see the number of defects per 1,000 births. Spina bifida, about 1 out of 1,000. Down syndrome, 1.2. Heart defects, 8. That's 1, 2, 3, 4 births. So easily the most common birth defect. And unfortunately, the leading cause of birth defect. Again, in 2013, 323,000 infants died of congenital heart defects. Again, that 323,000 people even died. It's an estimate based on infant mortality and diagnosis. Why did these happen? We don't. Some of them can be traced back to things like alcohol syndrome, drug use, or viral infection, but most of them are sporadic, and we don't really know why they happen. They're abnormalities of how the heart forms. So let's look at how the heart forms. The heart starts as embryonic mesoderm, one of the embryonic tissues that we'll look at much later this semester. But this embryonic mesoderm forms later as the heart, and we get these tubes called the tubular heart. The heart begins beating around 21 days after conception. So, 3 weeks in, you can see it. There again, huge tubes there, heart. It will very quickly begin to look like a normal heart. We have different areas. We have what's called the truncus arteriosus, bulbous cordis, the primitive ventricle, and the primitive. Around day 23, this magic trick starts where the heart makes this curve and it twists on itself. And what the bottom goes to the top. The truncus arteriosus becomes the aorta, the pulmonary trunk, the bulbous cordis, and the primitive ventricles become the left and the right ventricles. The primitive atrium becomes the left and the right atrium. The sinus venosus, they note in the coronary sinus. Walls partition off the chamber. Day 28, the ventricles partition. Then you see four fully formed chambers. Now, the fetus is in a different situation than you are, because for one, the fetus is not breathing. It's completely immersed in amniotic fluid. It can't breathe. So gas exchange takes place in the placenta. The fetus is not eating. Nutrient exchange takes place in the placenta. So the fetal circulation reflects this situation. We have different structures, umbilical arteries and veins, and then these ductus venosus, the ductus arteriosus, and the foramen ovale. So let's look at this. High oxygen blood returns through the fetus through umbilical veins. So big point here. This is fetal blood. Fetal blood and maternal blood do not mix. This is not maternal blood. What happens is back here at the placenta, what we get is we get these little pools of maternal blood here, and then we get tiny little fetal blood vessels out here, and we get diffusion. It's a chorionic. More on this later. But nutrients diffuse from the maternal blood into the fetal blood, which then circulates back through those umbilical veins. About 2/3 of the blood goes through the fetal liver. A third of it bypasses the fetal liver and goes straight to the vena cava through what's called the ductus venosus. So the ductus venosus, liver bypass. High oxygen blood, let's go back a slide. High oxygen blood, red, is going into the right side of the heart. Now remember, in the adult heart, high oxygen blood goes left side of the heart. This would be low oxygen blood in the adult heart. Here it's high oxygen blood. It doesn't need to go to the lungs then, because it's already got oxygen. So we bypass the lungs. We have a structure called the foramen ovale. Here's the foramen ovale. It's a hole between the right and left atrium. So that high oxygen blood comes into the vena cava, high oxygen blood, and it gets pushed over here. And then it gets pumped out to the body, down, up, and out. Screw to the lungs. We don't need to go to the lungs. We've also got a bypass here. This is the ductus arteriosus, so that any of that high oxygen blood that does make it into the right ventricle gets pumped up and out the pulmonary trunk, and instead of going out to the lungs, goes straight across into the aorta and out to the body. Now, after birth, both those structures heal. The foramen ovale becomes the fossa ovalis. The ductus arteriosus becomes the ligamentum arteriosum. So before we start getting into defects, let's talk about some terms. Patent means open. Stenosis means that a valve or something is narrowing. Cyanosis means blue. Ischemia means we have a lack of blood supply. Congenital heart defects get classified as cyanotic or non-cyanotic. A non-cyanotic defect, usually blood is moving from the left side to the right side. So high oxygen blood gets shunted to the right side. That's not going to make you blue. Cyanotic means that low oxygen blood is being circulated out to the body. That's going to make you blue. The first defect we'll talk about is the most common congenital heart defect, ventricular septal defect, a non-cyanotic defect. It's a hole within the wall between the ventricles. Now remember that your left ventricle over here is much stronger than your right ventricle. So when your left ventricle contracts, what's going to happen is it's going to shove high oxygen blood over to the right side. What does that mean? Well, that means there's too much blood on the right side, one. So you're going to have more pressure out here. Not out here. One out to the lungs. Pulmonary hypertension. And the heart has to work harder because it's not getting all the blood out that it meant to get out. Because some of it's getting pushed back and it's making a lap. So the heart does have to work harder. Most of these will close after birth. Some may require surgical repair. Prognosis is pretty good here. An atrial septal defect, something like a patent foramen ovale, where the foramen ovale does not close, is an opening between the left and the right atria. Again, this is a non-cyanotic defect. The left side of the heart is stronger than the right side of the heart. So high oxygen blood gets shoved back over here. Now, this can cause right heart failure. It can cause stroke eventually. Lots of these will go unnoticed. Usually you see symptoms before you hit like 40. The heart has to work too hard. Activity is not well tolerated. The heart just can't keep up with the demand because it can't pump out enough high oxygen blood because some of it's going back across to the right side. These can be surgically patched as well. Coarctation of the aorta is a narrowing of the aorta that we see here. The aorta narrows, and now the left ventricle has to work harder. This coarctation of the aorta is increasing after load. Over time, the blood pressure goes up as the ventricle walls get thicker, and this will eventually lead to other cardiovascular disease. Hypoplasia means underformed. Hypoplasia means the heart hasn't formed. Left hypoplastic right heart syndrome. Hypoplastic left heart syndrome is more common. Here's hypoplastic left heart syndrome. Blood comes into the right atrium, as it should, through the vena cava. It's going to go down into the right ventricle. Go pumped out to the lungs. All of this is normal. It's going to come back through the lungs into the left atrium. Now there's no left ventricle. So what does that blood do? The left ventricle is not strong enough to pump blood out to the rest of your body. The only way this baby lives at all is if that pyramidal valley and that ductus arteriosus stay open. If that happens, then that left ventricle can pump oxygenated blood over here, and you see the purple color that's in here. You get some mixing. Some oxygenated blood can go into the aorta. And because you've got this bypass here, the ductus arteriosus is still open, that mixed blood can go out to the body, and you get some oxygenated blood out to the body. This requires surgical repair, but the repair is not a fix. It's dealing with the best you got. It's not going to give you a fourth heart chamber. It allows you to function mostly with a three-chambered heart. 3 different stages here. Here's the result. They disconnect the pulmonary trunk and reconnect it to the right atrium. They take the aorta and they connect it to the right ventricle. And they cause the left atrium to connect to the right ventricle. So now the right ventricle becomes the new left ventricle. And there is no right ventricle. How does that work? Well, the right ventricle's got to pump blood in your lungs, and your lungs are right there. So right atrium can cover you there. This was developed in the 80s. Oldest survivors are in their mid to late 30s. We don't have long-term prognosis. Survival into adulthood with surgery is estimated at around 70%. Complications are common, and this may and most likely will require a heart transplant at some point. Tetralogy of Fallot, 3, sometimes 4 defects. An overriding aorta means the aorta opens to both ventricles, which allows mixing of blood. All right. So, overriding aorta, the aorta opens to both left and right ventricles. Pulmonic stenosis means the pulmonary trunk is narrow. Septal defect is a hole in the septum. And right ventricular hypertrophy means the right ventricle. Tetralogy of Fallot is the most common of the cyanotic heart defects. And it's characterized by cyanosis, especially when crying. The pressure in the thoracic cavity, shunting of blood over, low oxygen blood over to the left side from the body. And they may faint. A toddler has this over here that's called they draw their knees up. You see in this hands blue. Without repair, survival is only about 5%. With repair, survival rates are good. So, say good. People that have Tetralogy of Fallot, the most well-known would be Shaun White, the Olympic snowboarder, gold medalist, born with it. And Jimmy Kimmel's son, a couple years ago, was born with it. And as a coincidence, that night, Shaun White was his guest. So prognosis here is it's pretty good when it's repaired. Finally, we come to transposition of the great arteries, or transposition of the great vessels. This one, anatomically, is easy to understand. The pulmonary trunk and the aorta are reversed. So now, the right ventricle here pumps blood, low oxygen blood, out through the aorta. Pumps high oxygen blood right back to the lungs. So every immediate cyanosis. The only way this patient stays alive at birth is if ductus arteriosus right there stays open, and that foramen ovale stays open. That allows mixing of the blood. If necessary, we can do a balloon septostomy where we, much like an angioplasty, they push the balloon in and they open up those vessels to make sure that that mixing continues. Here is Bennett. Youngest, and he was born with transposition of the great arteries. So, toward the end of the pregnancy, our neonatologist, who I routinely made fun of for being alarmist, told us he wanted to go to a cardiologist. Now, in my defense, the kid before this, we were told some sort of abnormality. I don't remember what that one. The kid before that, we were told club feet. Actually, they delivered him a month early. Structural abnormalities, both of them normal. This being the third of the kids he had been involved with. I passed hard. I was like, yeah, you know what? Fool me twice, whatever. But he's like, no, I need you to go over to the cardiologist. So the cardiologist does the sonogram, and he's like, I don't see anything. And my wife said, well, he was worried about transposition. He's like, no, you're right, there it is. Got it. Yep, just saw it. So, it's going to have to be repaired after he's born. And I'm like, oh, who's going to do it? How serious? Well, if you have to have a congenital heart defect, one I'd pick. Because it can be fixed. So I'm like, oh, well, good. Like that being said, there's not a surgeon in Lubbock that can do it. Your choices are Houston or Philadelphia. I'm like, well, let's go with Houston. And he's like, good choice. That's the best person in the world to fix it. Why didn't you? And I'm like, okay, well, how long after he's born do we need to go? And he's like, oh, you don't understand. You're going now. Get your affairs together. You're going now. And I'm like, why? It's like, you can't have the baby here. If he's born in Lubbock, we would have to immediately fly him to Houston, and you can't go with him because a C-section. So you're going to deliver him in Houston. You're like, why don't we wait until it's closer to time of delivery? And he's like, you want to be on the road and then something happened in labor. So all of these were good points. So, and at the end of October of that year, we packed up to stay with my parents. We left for Houston, and we were in Houston for about a month. So here's Bennett, just a few hours after he's born. They immediately put in an umbilical arterial line to administer medication to him and monitor his arterial blood gas on oxygen. And you can see the cyanosis here in his feet. Here he is in the NICU, and you can see all the things over here. Being monitored in this monitor up here. Surgery here. This is the problem. We reverse those. That's here. Great. The other thing is that the coronary arteries, the arteries that feed the heart itself, have to be moved. Now, those coronary arteries have to be moved over to the proper aorta, pumping out low oxygen blood to itself. This surgery is around 5 days old. So at this point, the heart is strawberry sized. Not like a tiny strawberry, but like a regular strawberry. And these little blood vessels are fishing line. And they have to be moved. If you this YouTube link, I'm not going to do now, you'll see a video of Dr. Charles Fraser. Fraser at the time was the surgeon in the Texas Children's Hospital. He is now at UT Austin, I believe. And he is over 10,000 heart repair children. In terms of surgery in particular, he's amazing. He's amazing anyway. Surgery. I can remember reading. I don't think he's got any. We were very lucky that he was in Houston and that we could get there because he's in the world. Super nice guy. Brilliant surgeon. And this is a video of him doing that surgery. Definitely tip from the if you've got a kid that's going to have surgery, you probably should not watch a video of that surgery prior to it having the surgery, which is what I did. You know, with super accurate, like it shows the whole waiting room at Texas Children's and the whole procedure, like what are the same. Here is Bennett immediately after that surgery. Open. He's 6 days old here. So to make this happen, they have to do heart-lung bypass. So a machine takes over the function of his heart. He gets potassium to stop the heart. You see the coming out of him. He'll dialysis. A lot of fluid. Six days. So at this point, my wife has gotten to hold him one time before surgery, and no food or nurse. Here he is later. So this is all. I think we're around Christmas now. Still tubes. All the test tubes are gone. The arterial lab out, and we actually get done. At this point, he's in the cardiovascular. So at this time, the flight, I want the number was like 8 because we were between 2 others. To know the parents with the kids. Some beds on each side, and beds on the other side of the aisle. And so we were in the room with multiple infants. And of the people that we met there, we really to leave the cardiovascular ICU and go to the regular room, which you see here. At 11 days old, we're in a regular room. And the only things that are still freaking day. And when we met there, we were the only people that there were lots of kids that were hard to fix, things that. So we were we left the hospital 15 minutes when it was born. The recovery was extremely standard. Everybody and they let us take him back down the street to Ronald McDonald House where we were staying. We stayed there for 4 days and we went back and they checked him out and they told us to go home. We went back to Ronald McDonald House. And this would have been the 23rd. Decided to sleep. And then we got up about 9 o'clock, packed up all our stuff, threw it in the car. We headed for home. And we made it back on Christmas. So then here is Bennett. Bennett, I want to and it's and I really thought I had a good Bennett. I guess I did. 5. If you hear any screaming in the background of any of these, Bennett, it's loud. See if I find some pictures here. He's hilarious, and he's fine. The surgery was a complete repair. It doctors when they listen to him, it's funny they'll look on their face if they haven't seen it before. You can hear it. So an abnormal blood flow. You can hear the heart murmur that's created by the surgery, but that's what's expected. So he's made an amazing recovery. He's in great shape. All right. So cardiovascular stuff. I'll get cardiovascular lab stuff up sometime during the day, and then we'll probably plan on having like a Zoom meeting or something over the weekend so that we can get on the same page and kind of review. But that's it for now. I will talk to you guys later.